welcome again to the Epilepsy Podcast, and we are bringing Dr. Goodman on for a second time because we had so much fun with him the first time. But actually, we want to talk about temporal lobe epilepsy, and Dr. Goodman is really an expert, having performed hundreds and hundreds of temporal lobectomies and treated many of these patients over a long career. So I thought he'd be a great person to talk about temporal lobe epilepsy and anterior temporal lobectomy. Rohit, why don't you get us started?
Sure. Just to give our listeners a reintroduction to Dr. Goodman. Dr. Goodman is a neurosurgeon at Hackensack University Medical Center and has been an innovator in the treatment of epilepsy for more than 30 years. He established one of the first multidisciplinary epilepsy centers in New York City as a faculty member at Columbia. He's a scholar and has over 100 peer-reviewed publications to his name. After completing his medical education at Johns Hopkins University, he went on to complete his neurosurgery residency at York Presbyterian, Columbia University Medical Center. He later completed his fellowship training in epilepsy surgery at the Montreal Neurological Institute. Dr. Goodman, thank you for joining us on the show. I'll start us off today by asking you some questions. There are now 3 randomized controlled trials that show the efficacy of surgery for patients with drug-resistant epilepsy. 2 of these specifically focus on patients with temporal lobe epilepsy, and rates of seizure freedom with surgery hover in the vicinity of 60 to 70% at 1 year. Is it at all controversial in your mind that drug-resistant temporal lobe epilepsy is a surgical entity?
No, absolutely not. Temporal lobe epilepsy, when it's medically refractory, is a disabling condition, and living with the natural history, meaning living with medical treatment of epilepsy, is associated with significant morbidity and even risk of mortality that would be eliminated if the seizures are eliminated. So rendering a patient seizure-free yields them a dramatic improvement of their quality of life, but also extends the life expectancy for patients who live with this type of epilepsy. And now the experience from those randomized trials, which were extremely difficult to engineer, and it's fortuitous that we do have those, but even with all of the other experience with thousands and thousands of patients that have had temporal lobe surgery for refractory epilepsy, it's very clear that there is a very high chance of making a patient seizure-free and a very low risk of significant morbidity of causing harm to the patients. So I think even without randomized studies, it was extremely convincing that appropriate candidates are absolutely should be offered surgical intervention. And the randomized studies confirmed what we already suspected very reasonably from all the other experience.
So, Dr. Goodman, I got referred a patient, and actually you helped me with this patient. A patient with temporal lobe epilepsy was referred to me by an epileptologist for placement of vagal nerve stimulator. And as you recall, I think we ended up convincing our colleagues to go ahead and implant this patient and did a temporal lobectomy. And this patient's continued to be seizure-free now 2 years out. Why? The first question was a bit provocative. Should this be a surgical entity? And I sometimes think temporal lobe epilepsy that's not controlled with medicine should be thought a little bit like high-grade carotid symptomatic stenosis or something like that, something that everybody agrees we should operate on. What are we not doing in the field of epilepsy surgery to sort of get this message through?
It's extremely hard to answer that, I think. I think that it depends on the physician managing individual patients with refractory epilepsy, and it depends somewhat on the patients or their family members themselves becoming more informed about living with refractory epilepsy. Patients with epilepsy that end up being seen or treated by a neurologist that is at a comprehensive epilepsy center that offers surgical intervention for epilepsy on a regular basis if they are good candidates for surgery, they are typically offered that surgery, and they're usually offered it in a way that they find it very compelling to go along with it, and they do end up thinking of it analogous to other problems that are traditionally and typically treated surgically. I think the big problem with epilepsy is that it is primarily managed medically, and even patients that are good candidates to have surgery are typically managed for a number of years with medicine appropriately, are managed with medicine by neurologists that have extensive experience managing patients with epilepsy using medicine, but often not with a neurologist who has experience dealing with surgical treatment of epilepsy. And so very often that physician, that neurologist, is just not going to really think of surgery as an option. Many of those neurologists have already developed a strong opinion about whether surgery has a role for patients with epilepsy, and sometimes they are not adequately informed about the realities of who's a great candidate and what realities would be of a patient having surgery for epilepsy. So they often don't think of it for their patients or offer it to their patients. And that means that those patients sometimes have to be the ones to find out on their own that this is something they should consider.
Right.
And I don't know if that, hopefully that sort of answered.
Thank you. That's, again, it's a problem that I think we all think about a lot in terms of underutilization and why it happens. So this is a good segue into just talking a little bit about temporal lobe epilepsy that's untreated. And I'm curious, you know, I don't know, maybe you can estimate how many hundreds of temporal lobe epilepsy patients you've seen in your career, but it's a large number. Can you talk a little bit about
more than a thousand? I know that.
So can you talk a little bit about what these patients look like? So for example, we know from literature that these patients can have neuropsychological, psychiatric, cognitive comorbidities. In my own practice, I almost can't think of a temporal lobe epilepsy patient who doesn't describe bad memory, short-term memory loss, learning problems. Up to a quarter of them have major depressive disorder, anxiety. So can you talk a little bit about the cognitive phenotype of the temporal lobe epilepsy patient, and what are some of the causes of them having ongoing seizure activity over a long period of time?
But I'm going to preface my answer by pointing out that my vast experience with epilepsy patients are epilepsy patients who have refractory epilepsy. So these are patients that have not had their seizures come under control with medication. So the majority of epilepsy patients actually do get their seizures controlled by medication very effectively, very often with a relatively simple regimen on medicine. And those patients, I never meet them. Pretty much. I actually have met some of them. Maybe we can talk about that in a minute. But in general, the patients that I have met are patients that have lived with epilepsy for quite a few years usually, and have seizures that are not controlled completely by medication. So that subgroup of patients, actually, it's probably about 30% of patients overall. A large percentage of them are patients with temporal lobe epilepsy, and it really depends on whether to some extent, it depends on whether their epilepsy is coming from their dominant temporal lobe or not. Because patients that have seizures from their dominant temporal lobe, the temporal lobe that is responsible for their language function, are more impaired over time than the ones that have seizures coming from their non-language, non-dominant temporal lobe. But patients with seizures from their non-dominant temporal lobe also have very significant quality of life impairment and disability related to that, but it's significantly different because the ones that have it affecting their dominant temporal lobe generally have more of an effect on their memory function, their language function and their memory function over time. Those patients typically, and usually have had epilepsy for many years, usually more than 10 years of seizures, of refractory seizures, before they will notice some decline in their functioning. But then often once they've noticed it progresses significantly over a relatively short period of time. It almost seems like it's a rapidly or somewhat rapidly changing problem. It can change over a period of a year, but it's probably, the change in the brain has probably been happening gradually for the entire time that they've had that epilepsy. It's just that the brain has a significant reserve capacity, and you probably have to deteriorate the brain a significant extent before it starts to be noticed as a symptomatic problem by a patient. But this memory decline is very common among patients that have temporal lobe epilepsy from their dominant temporal lobe. And once they've noticed the decline, in my experience, it mostly seems like it's because that temporal lobe has really severe impairment of function as far as memory goes, verbal memory, and remembering stories, especially, which is a type of memory that is really critical for people that they use all the time and rely on. And that type of memory starts being impaired, and it can be very bothersome to people. And it's because they've had to shift to relying on their right non-dominant temporal lobe. We can't say that for sure in every individual patient, but in many patients, I think it's because they now are trying to use their non-dominant temporal lobe to serve the function that they used to use their dominant temporal lobe for. And so in a way, that is a favorable thing for patients that have refractory epilepsy coming from their dominant temporal lobe, because that problem actually makes them better candidates for surgery because they're less likely to have any change in their functioning due to a surgery. And so it's in a way, it's good. It's different with the non-dominant temporal lobe because we don't rely on our non-dominant temporal lobe nearly as much. And so if somebody loses the functioning of their medial non-dominant temporal lobe, it doesn't change their functioning significantly by itself. The other problems that you mentioned, I don't think are related strictly to a problem with functioning in the medial temporal lobe. I think it's an effect of living with those seizures. The seizures affect on the brain and living with those seizures, but the psychiatric comorbidity, which we don't understand fully, but probably has to do with a more general dysfunction that affects the temporal lobes. Patients can have a bad prolonged seizure and have a post-ictal psychosis, which is not terribly rare among patients that have temporal lobe epilepsy, or they can have very common to have depression and other mental health associated comorbidities because they're living with refractory epilepsy, probably multifactorial why they develop these problems. But we do know that if a patient is cured of their epilepsy in a relatively short time after they've developed refractory epilepsy, let's say within a couple of years, instead of 10 or 20 years living with refractory epilepsy, that they are much less likely to have to live with those comorbidities. The verbal memory issue is a separate issue, which is a little more complicated, but at least you know that you can avoid those other comorbidities.
Thanks for that answer. Yeah, it's so you pointed out the differences between dominant and non-dominant temporal lobe surgery. I remember some of the first dominant temporal lobectomies that I did. I was surprised by how much temporary aphasia the patients can have after surgery. Can you talk a little bit about when you're counseling these patients pre-surgically? Obviously, you mentioned visual field issues that might occur. You mentioned on the dominant side memory issues, and then how do you prepare them for language dysfunction that they might experience postoperatively?
Well, the language function that you're talking about is separate from the memory issue that I was just referring to. The language, having difficulty actually communicating, expressing yourself effectively or comprehending well, that can happen just because of a temporary disturbance of the temporal lobe near where a surgery is done to remove portion of the temporal lobe. So that area can get disturbed, very commonly does, and a lot of patients on the dominant side will initially, after surgery, they may wake up and actually their language function might be quite good the first few hours after they wake up. And then they may develop a significant problem with that type of language, of receptive language and expression even to some degree. And that can be, it looks like it's because of a reaction of the nearby brain to the surgery that is a temporary problem, that the brain is going to recover. Typically, it takes days for the brain to recover completely from that. So I always tell patients that have dominant temporal lobe surgery that they might experience that kind of a temporary problem that will get better. That's separate from a verbal memory issue or naming problem, which can be permanently changed because of a removal of tissue from the medial temporal lobe, the dominant temporal lobe. Probably less severe when we do an ablation of the hippocampus and the adjacent tissue, probably less significant change in this verbal memory or naming problem than when we do an open surgery, an actual resection. And that's one place where the laser ablation procedure, has a really significant role to play, I think, for patients in that category.
Thank you, Dr. Goodman. While the surgery freedom rate with the anterior temporal lobectomy is pretty impressive, it's not 100%, and up to a third of patients continue having seizures. What are the reasons that surgery fails in these patients, and how do you approach these patients, and what results do you encounter with repeat surgery?
I think it's a real challenging problem with this entity, with dealing with surgery for the treatment of refractory epilepsy. We try, obviously, very hard to get a very clear idea of what part of the brain is responsible for a particular patient's seizures. And we can do evaluations, sometimes including invasive electrode evaluation, to get the information that we feel we need to have an excellent chance of being able to offer a resective surgery or an ablation type of a surgery that's going to cure their epilepsy. And almost always, we are well over, have a significantly higher than 50% chance of making a patient seizure-free with that type of surgery when we recommend it. We could always try to get more information about an individual patient, but in order to get more information in certain cases, we would have to expose a patient to increased risk, another surgery, more time in the hospital. And so, and when we have patients that are already at a 60 or 65, 70% chance of being cured by a surgery, the chances that further investigation is going to raise that chance of curing them significantly is not great. So we have to accept the idea that there are going to be some patients that we just did not cure them because we did not remove, we may have removed tissue that was critical or a significant player in their seizure problem, but obviously it wasn't enough to eliminate their seizures. So we know in those cases, each one has to be analyzed individually, and we have to go back and look at what our basis was for thinking that that was their seizure focus to begin with. But in some cases, we have good reason to think that their seizure focus was partly removed by a surgery, and that it could be that they have a seizure focus that extended a little bit beyond where we initially thought it was. In those cases, we might have an excellent chance of curing them by doing another investigation to look at the tissue near the prior resection to see if that seizure focus extended into those areas, and it might be amenable to a resection. In some cases, each one is, like I said, is an individual case. In some cases, we have removed tissue that, as much as we felt was safe to remove without causing a neurologic impairment. And so in those cases, we may actually have a suspicion that their seizure focus is in an area nearby that cannot be safely removed. In those cases, we might recommend what we call neuromodulation approach, where we might implant a stimulation system to try to modify their seizure problem that would be safe and not involve removing tissue. And in some cases, especially we were talking about the temporal lobe, and it often can be the case with temporal lobe patients, where we thought that all of their seizures were coming from one temporal lobe, and it could be that actually they have an independent generator, possibly in their opposite temporal lobe, and that also would not be amenable to a resection safely, but could be helped by a neuromodulation approach. So each case is very individualized, and I think it's very critical when we have a patient that we thought was going to be cured by a resection, and they weren't, for us to very carefully analyze that patient and try to figure out why that patient wasn't cured, and then see if there might be a chance that we can offer help by a further surgical approach potentially.
Thanks for that answer, Dr. Goodman. Yeah, we got to write together that book chapter on repeat epilepsy surgery, and we looked at all those reasons. Obviously, often in the temporal lobe, either there's residual mesial structures that are part of the seizure onset zone that weren't removed, residual posterior cortical structures or basal cortical, or bitemporal epilepsy. And those seem to be the most common reasons. Talk a little bit about, you were involved in a multi-center study on gamma knife radiosurgery for MTS. How has this affected your own practice? When do you think this is an appropriate way to treat a patient with epilepsy? You're smirking. I notice I don't see you use it that
no,
often.
I'm smirking because of, I mean, it's not just this particular study, but it's the case I've learned from being involved in a number of different surgical research, clinical trials involving surgery for epilepsy or for other things. But most of my experience has been with epilepsy trials. And in order to perform a trial like this, you conceptualize the trial, let's say in year 1, and then it takes a year or 2 before you even get a final version of what your trial is going to be. You have to get multiple centers signed up to participate in a multi-center trial like this. And then it takes years to complete the study and to get the results, right? So it's years. And some of these trials are trials of a new technology that's been developed to try, or a new idea of how to apply a particular technology, like this one was. So some early experience with the gamma knife suggested that it could be used to basically ablate the medial temporal lobe, the area that we would typically remove surgically to treat patients with medial temporal epilepsy. And the concept was a great idea. It took years to carry out the study to actually treat a significant number of patients with this very high dose of focused radiation to their medial temporal lobe. Actually, it is the highest amount of radiation delivered to the brain in a treatment with using stereotactic radiosurgery that's ever been done or ever could be done, because treating at a higher volume of tissue with that type of a dose would be extremely dangerous. So we know that we couldn't go much further than what we did in that group of patients. And it turned out that we could accomplish the goal that we had, which was to have a very high rate of seizure control and very low rate of significant morbidity, right? One of the big drawbacks, though, is that radiosurgery, when we deliver it in 1 day as an ambulatory procedure, doesn't have an effect on the seizures until about 10 months later. So those, and in fact, during those 10 months, many patients would have a flurry of seizures, some increase in their seizure frequency, waiting for the tissue to respond to that radiation treatment. And then at 10 months, they would become seizure-free and then stay seizure-free. But they also had some risk of developing significant brain swelling that sometimes needed to be treated with steroids, which is a significant treatment and sometimes would have to be treated for weeks. And actually, some of these patients had enough swelling that they needed to have a surgery, so the same surgery they would have had without the radiation, right? So it was a good study. It showed that it could be an effective treatment. But the problem is, during those years, laser ablation also was developed. During all the years that that study was being done and the results were being obtained, laser ablation was developed. And laser ablation is actually, it turns out, probably a better way to accomplish the same thing for a couple of reasons. It's a minimally invasive. It does require actually putting something physically into the brain, but it's a tiny catheter that gets put into the brain, very low risk of causing a complication. And we can deliver thermal energy to the target area in the brain, the same target area, with much less risk of significant swelling, less risk of morbidity, and has immediate results. So if we do that procedure, which could almost be, in some cases it is an ambulatory procedure, but certainly would require only 1 night stay for almost every patient in the hospital. They go home and have basically no recovery that they need to go through, and they're cured instantly after the procedure. So that has pretty much eliminated candidates for the the stereotactic radiosurgery, a gamma knife approach.
Thank you, Dr. Goodman. Now, something interesting that you've been focusing on is you've been using focused ultrasound for essential tremor. Can you tell us the basic idea of this technology and whether you think it could have any role in the future of epilepsy treatment?
Yeah, focused ultrasound is another one of these technological advances that's so incredible. It was a concept from, I think it was in the 60s, the first doctors, or maybe the 50s, that thought of being able to use ultrasound to heat tissue and to do it in a very accurate way where we could potentially focus ultrasound waves so that they would heat up tissue deep in the body somewhere. In this case, it would be in the brain, without heating any or affecting any tissue anywhere else other than where it's being targeted. So it's basically extremely analogous to the way we use stereotactic radiosurgery. It is many hundreds of beams of ultrasound waves that all meet at one point. And when they figured out how to apply this to the brain, they figured out that there was a way to get ultrasound waves to penetrate the skull. Then they could develop a way to do this and actually have a patient's head, brain, in an MRI scanner at the time that they're using the ultrasound waves to heat the target area in the brain. And actually, the MRI allows us to see the temperature of the brain tissue. So we could actually confirm that we are targeting the exact area in the brain that we want to aim at, and we can control how much we raise the temperature. So we could actually raise the temperature enough to make a temporary effect in the brain and make sure that it has the effect that we want before we actually heat it up enough to permanently affect it. So it's been used, only so far approved to use to treat tremor, because there's a target in the brain that's a tiny target, only 4 millimeters, or about 4 to 6 millimeters in diameter, basically, that we know if we lesion that area, we can cure a patient's tremor without causing any problem. So it's been an excellent procedure for helping patients with tremor. To be able to apply it to other things depends on the individual details of a particular patient's problem. That it has to be, the target has to be deep in the brain, and there are some targets deep in the brain that cause seizures that could be amenable to this. Has to be small enough to be amenable to this kind of heating safely, and there are some other things, the skull density and things like that. But basically, what it comes down to is a deep, small target in the brain that has a good chance of curing the epilepsy if we were to lesion that area. So the same kind of targets that are targets for thermal ablation could also be targets for the focused ultrasound approach.
You have hypothalamic hamartoma already, right?
Exactly. Hypothalamic hamartoma, or even potentially, small cavernous malformation somewhere deep in the brain that you're concerned about.
Paraventricular nodular heterotopia, maybe.
Yeah, nodular. But these are the same things that we also currently can often successfully approach with the laser ablation approach. There might be a role, though, for using focused ultrasound instead of laser in some of those cases, but that's going to take time to figure out. And right now, it's not high on the agenda of the company that makes the focused ultrasound to try to apply it to refractory epilepsy yet.
Dr. Goodman, just to sort of wrap things up a little bit, talk a little bit about your career, because just in general, you've been able to balance a busy clinical practice with really substantial research output, being involved in a lot of different trials, being involved in creation of, various really important technologies, RNS being part of what you've contributed to. How have you been able to attain that balance? What advice do you have for surgeons going into this career?
Well, I think that one of the main things that allowed, or two of the main things that allowed me to be as successful doing what you just described as I have been, is that I was able to focus my practice almost exclusively on functional neurosurgery.
So I thought you were going to say that you married well is number one.
Yeah, right. I'm sorry.
You told me that before. So I knew that was
that. Yeah, you're right. Well, she's not listening right now, so I didn't mention it. But anyway, maybe she'll listen to this sometime. I should have said that. No, yes. But being able to focus my clinical practice very focused on functional neurosurgery allowed me to have a very large experience over a short period of time with those particular patients. And that was extremely helpful to be able to focus on. I was able to do it on a couple of different areas, but if you, let's say, just said epilepsy, if you can have a very substantial part of your practice be epilepsy surgery, then over a relatively short period of time, you can have a lot of experience and become very expert at dealing with surgical treatment of epilepsy. But the other thing is being in a place where you have colleagues that you can collaborate with that are going to allow you to accomplish these kind of things, because none of these kind of trials, the clinical research, cannot be done by a single person by themselves. It has to be a team effort, and being in a place that has the right team available where you can have the right people working together. I was at Columbia, I had excellent people to work with, and that facilitated my ability to pursue those kind of research activities.
Dr. Goodman, thanks again so much for your time. We appreciate it.
Okay, sure. Pleasure.
Okay, see ya.
Okay, bye-bye.
Thank you for listening to the Epilepsy Podcast. The video content and audio content is not intended to be a substitute for professional medical advice. The views and opinions represented here are merely the views and opinions of our expert guests. Thank you.